Welcome to Cardiovascular Matters. Whether you are looking for answers for yourself or someone you love, we are here to give you the best information available. Each week, the founder of Cardiovascular Institute of the South, Dr. Craig Walker, and medical device sales veteran Terry Roberts discuss the causes, symptoms, treatment, and prevention of health-related issues stemming from cardiovascular disease. Now here's your hosts, Dr. Craig Walker and Terry Roberts.
Hello, everyone, and welcome back to Cardiovascular Matters. Really interesting topic today. We've talked about this a little bit in the past, and both Dr. Walker and I are, recipients of this medication we're going to talk about, and we've had great results personally ourselves. I know if you go back in the episode, you'll see the one where I kind of talked about my story, where I've lost over 100 pounds and been able to maintain and keep that. Has totally changed my life, and I tell Dr. Walker he saved my life. But the topic today is on GLP-1s. I mean, it's the biggest, probably the hottest thing going on right now in, I'd say, the weight loss scene, but there's a myriad of other health benefits to it, and we want to talk about some of those today. There's two medications that are approved today, and these are peptides. It's the first one is semaglutide, and the second one is tirzepatide. Dr. Walker will talk about the brand names and what's approved. But also, there's some other ones out there that are being studied now. There's one called retatrutide, and there's also cagrilintide. I think that cagrilintide is going to be combined with semaglutide, and that'll form a new agent. And they bring some tremendous advantages when you're trying to diet or lose weight. And one of them is just shutting off the food noise. I was telling Dr. Walker, some of the GLP-1s that I've used through my journey. I mean, you talk about food noise. I was always so hungry when I dieted, and now I'm not. And what's really amazed me is how little food you actually need to have a real healthy life. And I eat a fraction of what I used to, and I've never felt better in my life. So, Dr. Walker, I'm going to turn it over to you. I can't wait to hear this update about what you're seeing out there with GLP-1s.
Sure. So GLP-1s stand for glucagon-like peptide agonists. Mm-hmm. And they're a class of drugs that were developed for diabetes treatment. And we know we have epidemic rates of diabetes throughout the United States. And in fact, for most of the industrialized world, this has become an epidemic problem. But associated with that were healthcare problems. And that got me very interested with the healthcare problems. Because, historically, our method of treating diabetes was to control blood sugar. And we thought that as we control blood glucose, that if we did a good job of that everything else fell in place. But it does not. People still are more risk of recurrent heart attacks, recurrent death, kidney failure, all of these other things. So along came two new classes of diabetic drugs. The SGLT2 inhibitors are sodium glucose transport inhibitors, and we're not going to speak of those today, but also the glucagon-like peptide agonists. Mm-hmm. Now, these drugs work. The GLP-1 agonists slow the transition of our food through the intestinal tract. Right. So as we take these, everything is slowed down, and so we don't have the same big spikes noted in blood sugar. And they are very effective in controlling blood sugar. And in my experience, at least, it seems as though they keep the glucose levels or the blood sugars much closer to the baseline of normal without the big spikes of high blood sugars and low blood sugars. That has certainly been what I've seen more in my patients, particularly those that I have wearing glucose monitors.
Oh, wow.
But it became very obvious that these drugs had additional effects. So right now, the two most used of the GLP-1 agonists, so the ones that I personally have looked at the most, and they have the biggest indications. The first of all to come out was semaglutide or semaglutide, and many pronounce it each way.
I do. Yeah.
And this is a pure GLP-1 agonist. That's what it does. And it does certainly lower blood sugar. It seems to slightly lower lipids as well.
Oh, wow.
But this drug has already now have proven benefits that the FDA has recognized. So it decreases MACE. MACE stands for Major Adverse Cardiovascular Events. So what are those things? Death, heart attack, heart failure, stroke. It decreases those. It decreases those significantly. Via a trial called FLOW trial, it's been shown to protect the kidneys in diabetic patients. Now, why is that important? Well, kidney failure is very common in diabetic patients. Not a small thing. It is a big thing. And regardless of what one's glomerular filtration rate, in other words, how bad the kidney function is to start,
Right.
these medicines have been shown to decrease the likelihood, the semaglutide, to decrease the likelihood of that kidney function getting worse. That's a big deal. That's a really big deal, as so many of these patients otherwise end up over time on dialysis. And certainly when we could avoid that, that would be a great thing to avoid. I've never met someone who said, I'd like to get on dialysis.
Right.
Right.
Right. No.
And so I think some of these things are changing the way that we look at a diabetic patient. It's very important to look at this. Now, these medicines have also shown to decrease the likelihood of rehospitalization. And that's true for both of the medicines I will speak about. We don't yet have an FDA indication for that, but it seems as though in early studies, and that they have that impact. Now, I've mentioned semaglutide already has an FDA indication to decrease MACE, or major adverse cardiovascular events, to decrease rates of kidney failure. But there are now projects working. We do not have publications yet on these, but looking at its anti-inflammatory properties, looking at whether or not this may help with preventing dementia, whether this may help with addiction to other
right.
things. So these are certainly very, very interesting areas, and areas that I think can have a lot of room for us to improve. Now, the other that is being used tremendously, and it also has a weight loss indication, but it also has a sleep apnea indication now given by the FDA. Now, and that is tirzepatide.
Right.
Now, let's go back, because I failed to mention with semaglutide the two names. The drug, these two drugs are made by the same company. It is exactly the same drug, just different doses and different indications. If we're using semaglutide for weight loss, or if we're using it to diminish cardiovascular events, we can call it Wegovy. On the other hand, if we're using it to control their diabetes specifically, we have to call it Ozempic. Same exact medicine. I think they do this to make doctors confused. I'm not quite sure why we can't just write semaglutide and write the dose with it, but the FDA apparently has some reason for that. But that was mandated.
Yeah.
So the second agent, tirzepatide,
Right.
is marketed in two ways too. If it's used for diabetic control, and they have an indication for that, okay, then we call it Mounjaro. If it's being used for weight control or for sleep apnea, we should call it Wegovy. Not Wegovy, forgive me, Zepbound. It's called Zepbound. And once again, same drug, same route of admission, same company. It just can be different dosages. Once again, I find this confusing. It would be much easier for me if we just looked at these indications for this. Now, These drugs typically are not to be used if someone has a history of multiple endocrine abnormalities, or if they're a diabetic who's had problems with gastroparesis, where the stomach does not empty very well over time, then these can really cause some problems. These drugs seem to perhaps intensify our response to alcohol. And when I start patients on these, I strongly urge them to avoid alcohol totally at first in starting, and later on, if they're going to have any alcohol, to do so in very small amounts, because this does sensitize the pancreas as well. But, these drugs are really, I can't ever remember a drug like this where patients were coming into my office and saying, "Doctor, can I be started on these drugs?" Which I find amazing. This is interesting. And, despite the fact that we see that there are side effects, and those side effects relate to the slow gastric emptying, which can result in constipation or diarrhea, or, it may precipitate a gallbladder attack, again,
Indigestion.
and liver and indigestion.
Yeah.
Despite that, in all the trials that I've seen so far, the discontinuation rate was no different than that of placebo, giving an injection that had nothing in it at all other than just fluids. And so obviously people adhered to it. Those people didn't know whether they were on it or not, on the drug or not. These were randomized controlled trials. So one person gets something that really doesn't have the medicine.
Oh, wow.
So they seem to be pretty darn well tolerated in most patients. Some patients can't take them. Some patients shouldn't take these medicines. And certainly your doctor can help with that. And certainly we should use these cautiously and build them up. But when I first read of these, I thought, boy, this is really good what it can do for diabetes. But I never once dreamed that they would have greater impact on obesity than anything that's come out in the past, that they would, lower our death rates, that they could protect our kidneys, etc. Now, as I've mentioned, the indications that semaglutide has. Tirzepatide has not, it's not been around as long. Studies are going on, in other areas, but as of yet, the only indications that the FDA has given, to my knowledge, are those that I've mentioned, the ones for treating obstructive sleep apnea and the one for controlling diabetes. And it may well be that they do well as well, but we don't have that where the FDA has been able to analyze the data and say, yep, that's right, and that's what they see. And then, as you mentioned earlier, there are a whole host of new agents being looked at. And for me, at least, this gives me some hope, because, I find diabetes to be one of the most difficult diseases that we've ever had. It results in so many bad things. So many organs get involved: eyes, brain, heart, kidneys. It's really a destructive disease process. And I really think we're going to see a tectonic shift in the future of how we treat diabetes. These drugs right now are expensive, but at some point that's going to come down. And I really think the future in diabetic care is patients are going to be started early on GLP-1s and SGLT2s, and perhaps we may have an opportunity to limit some of these terrible complications of diabetes. Terry, your thoughts?
I agree with you, Craig. I mean, I know literally just in the last year or two, the prices have come down. I mean, a lot of patients, if you don't fit the in the box for the certain indication, your insurance company may not cover it. But the companies are stepping up, I believe, and they're offering alternatives. But I've seen the prices come down, which I think are going to make it more available to most folks. But I can tell you this it's vitally important to me, and like I said, it changed my life. I've never felt better, and it was just such a hopeless situation to be overweight, and you diet, you're so doggone hungry and just struggling with it every day. It's on your mind every moment. And it's an incredible drug. And I mean, or peptide, I guess a hormone. I'm not exactly understanding, if we should call it a drug, a medicine, a peptide, a hormone, but it's an incredibly effective agent. And you mentioned that, some people can't take it, and they can't, but I find, I think the vast majority of patients can tolerate it well. And, the biggest side effects, I guess, are, you said constipation, diarrhea, maybe indigestion, those things. But, you got to kind of watch what you're eating, and then also, take magnesium. That's also a big, big help. And it'll help you sleep, too. So those are some of the things that I kind of do, and it works out great for me.
Terry, I failed to mention one thing. And so with Mounjaro or tirzepatide, or Zepbound, it's all the same. All those are by Lilly. Actually, there are two agents. There is the GLP-1, which we've mentioned, and I forgot to mention the GIP. And that stands for glucagon like insulinotropic polypeptide. Okay, so this is a little different. It that may help to somewhat mitigate some of the indigestion that some have, and that's why that was added. So it is not a pure GLP-1, but it has this GIP activity. There's another area I failed to mention, and I should not, because it's an area of very intense research right now that may prove to be very interesting with GLP-1s. It's being looked at as something to help with drug addiction.
Right.
And I don't know how I could have missed that, just thinking about it, because this has really captured my imagination. Because as I see patients started on these agents, I watch them transform. I mean, there are patients who have a feeling of well-being on these. It's almost a high, I guess. I don't know how else to describe it, but there's a bit of a euphoria, and it's doing something in the brain. I can't yet speak as to what that is. I don't know.
Right.
I don't own stock in these companies at all.
Right.
I just, it's just, I'm intrigued by them right now. I think they're very, very interesting drugs that offer great promise. We're going to see other drugs that combine things, but this represents, I think, a revolutionary breakthrough. And it has given us some extra understanding of diabetes above and beyond just an elevated blood glucose. Okay, and that's so important. And, all along, I've always been mesmerized by the fact that there are people who have pretty poorly controlled diabetes all their lives and really can live pretty long and don't have problems, and others succumb at a very young age to the most ravaging disease that you could imagine, with organ system after organ system failing. And, there's a lot we still don't understand, of course, and that's true throughout all of medicine. Whenever we start thinking we know a whole lot, we realize we have a lot of things we don't know at all. But nonetheless, this represents monster breakthrough in how we approach the treatment of diabetes, but also, and that was my initial interest, but now more and more, I must tell you, diabetes is a real disease. Diabetes is not just a symptom, it's a real disease. And obesity is a real disease. So, Terry, forever I have looked at diabetes, and I've looked at obesity maybe differently. Obesity was something we say, I eat a little bit less, exercise a little bit more. But, obesity is a disease. It's associated with higher rates of cardiovascular death. It's associated with orthopedic problems. It's associated with more sleep apnea. The list goes on and on and on. Obesity is a disease in and of itself that we have to be able to address. It's very important. Now, we know that when we put people on GLP-1s, we know, yes, they eat less. We know that their hunger is better. But one of the things that's been noticed with some of these medicines is in the trials, resting heart rate is slightly increased. And so what difference does that make? Well, when we go out to exercise, we may walk or run for 20 minutes a day, but your heart is beating every second 24 hours a day. And if it's not, you're in trouble, right? It's okay. And the heart burns up a lot more energy than our musculoskeletal system. So I think that's part of why we see accelerated weight loss as well. But I've got to tell you, we have to quit stigmatizing obesity and do a better job treating it, because
Right.
a lot of people are miserable with it. And, the thing we think of most is people don't like the way they look. And that's true. A lot of people don't like the way they look if they're obese. But, there's so much more to it. And in particular, the feeling of just feeling good is improved when we can deal with obesity. So I think we have great opportunity here, and we're going to have an upcoming a podcast in the future where we have a person who's actually board certified in psychiatry, cardiology, and weight loss management. I said that he's board certified in all three of those areas. Who's going to speak to us about obesity, about some of the psychological issues with obesity, about some of the biofeedback mechanisms we can use, about yoga, you name it. But I can't wait to have this podcast, because very, very intelligent, very exciting concept that I think we can all learn from.
Absolutely. Yeah, it's definitely multifaceted, and medicine, about like you said earlier, about the time you think you're kind of there and you got things figured out, there's so much more research and there's so many more things to be learned. And that's what's unique about it. It's a benefit to the patient, but it certainly keeps the physicians on their toes, because you've got to want to constantly learn and update yourself. You just dial this thing back 3 years ago, and where we're at today. It's unbelievable.
You bet. I tell my fellows that I train, if you're not willing to keep learning, change
Right.
fields.
Exactly.
because what's considered dogma today is passé in the future.
I always think about, the devices that we were using 20 years ago seem barbaric compared to what we have today. The improvements, and you gotta really take your hat off to the collaboration between the physician community to bring, to sit down with the industry and say, hey, here's what we really need. You guys need to work on this. And that collaboration so important. And the same thing with these GLP-1s on the pharmaceutical side of things. Tons of research going on in this. And we talked about this briefly. I'll just throw that out there. But I predict within about 5 years that, this will be like taking a vitamin. I think people will just be, protecting themselves with these and keeping their weight off. And we're going to be a healthier nation because of it. So what an interesting podcast. And it's something, that I have lived myself. So I'm very proud and interested to put this out there. And, again, this is for educational purposes. Get with your healthcare providers. This is something that you're going to need guidance on, and you're going to need to be, there's surveillance involved in this. You can't just go with it. But it's a wonderful thing. And what I would recommend is that you stay close to your healthcare providers, or you can also find Dr. Walker's group at www.cardio.com. Very easy. And be sure and like and follow this. If you like our information, be sure and subscribe. It's free. And we'll see you on the next episode of Cardiovascular Matters.
Thanks for listening, and please subscribe, like, and share this podcast with your friends and family. Join us next week for new topics and answers with Dr. Craig Walker and Terry Roberts on Cardiovascular Matters.